All right. So when I'm sharing my screen, I can't see the chat. So I will just plan on presenting for a little bit, and then at the end, there'll be some time for questions. So with that, my name is Tirzah Wethern. I'm one of the addiction medicine physicians, and I work over at CeDAR, which is a substance use disorder treatment facility where we offer all levels of care. But my background training is in addiction medicine and family medicine. So today I'll be presenting on kind of a brief addiction medicine 101 course about how we care for patients who are struggling with substance use disorders. And with that, I have no relevant disclosures. And our objectives today will be to talk a little bit about the language that we should use when we are caring for patients with substance use disorders. I'll talk about the field of addiction medicine in general, and then how we establish a diagnosis of a substance use disorder, the overview of treatments for substance use disorders, and then a couple of slides about the specialty populations that we deal with, including folks who are pregnant and adolescent patients. So my first slide really focuses on the language piece, which I think is so important with these patients. Oftentimes, patients with substance use disorders do not seek out medical care that they need for several reasons. First and foremost, they're often very worried about the judgment that they're going to experience from providers, usually because they've had poor experiences in various treatment settings, whether that be when they were in a moment of crisis, in an emergency room, or experiencing acute intoxication and getting care. So for those folks, it's really important to use person-first language. So I have a nice little picture here that shows some do's and don'ts of the language that we use for patients, but we no longer use phrases like drug user, addict, junkie, druggie, alcoholic, but instead we say that this is a person who is struggling with a substance use disorder. And then the other big one that I like to highlight is the phrases clean and dirty. Sometimes patients will still refer to this. It's very common in the carceral setting, saying that they had a clean UA or a hot or a dirty UA. But the way that we should be documenting it in our notes is that there was a urine toxicology test that had positive results or unexpected results or expected results. So that's a way to kind of shift the way that we're talking about things. But in general, substance use disorders are not voluntary or a choice, and they are not a moral or spiritual failing or a matter of willpower. So those are just some key topics that I like to highlight for the field of addiction medicine in general. So what is addiction medicine and who can be an addiction medicine physician? But really, any specialty can complete an addiction medicine fellowship. So like I said earlier, my background training is in family medicine, but my co-fellow was emergency medicine trained, and there have been OBGYNs, pediatricians, internal medicine docs, and most recently an endocrinologist who completed the addiction medicine fellowship. So really we come with a lot of background in various subjects, and that really aids us in who we serve. So if you're thinking about what addiction medicine physicians do or who we see, basically, the biggest catch-all is that we see patients who have a known history of a substance use disorder who are interested in treatment. But also, we see a subset of folks who might have some use history of various substances that is problematic or concerning from a provider standpoint and patient standpoint, and they're just not quite sure if they actually meet criteria for a substance use disorder. So we're happy to see those folks and provide some diagnostic clarification for them on if they do meet criteria for a substance use disorder or not. I think another big thing that providers want to know about is how do you refer to us? So I just put a little brief bit here, but the first and foremost thing that I request from folks before we get a referral is that the patient consents for the referral. I have had several times when patients show up not knowing what specialty they're seeing that day. And when I share with them that I specialize in addiction medicine, it can disrupt the rapport that I then have with the patient, as well as the referring provider has with the patient. So I just always encourage people to talk with their patients before they send a referral to us. But in general, if folks are less than 18 years old, The common place that I send folks are the Denver Health Step Clinic, but I do know that Dr. Sandhu is completing an addiction medicine or an adolescent medicine fellowship right now at Children's, and she just completed the addiction medicine fellowship this year. So I know she's happy to see adolescent patients as well. And I have a slide later on that kind of outlines some other bigger treatment facility places that will take adolescents. But if you are within the UC Health system, feel free to refer patients to CeDAR if they're greater than 18 years old. And there is a referral in Epic that you can select for CeDAR. And then if they're pregnant within the UC Health system, you can place an Epic referral for the Addiction Obstetrics Clinic, which is kind of run by Dr. Klee, who is our guru in perinatal substance use disorder treatment. And so she said that you can either email or send her an Epic message if you have a patient. And then for outside of the UC Health system, CeDAR will still take folks, but there's also Denver Health, Denver Springs, Porter, kind of any psychiatric hospital will take folks as well. So those are some other considerations. And then a note on who is not appropriate for referrals to addiction medicine. Again, patients who do not consent to the referral, and then patients who are on chronic opioid therapy without a comorbid opioid use disorder. So unfortunately, we are not pain clinicians, so I am not able to take over prescriptions like chronic opioid prescriptions. Usually if we're doing that, it's in combination with either a primary care doctor or the pain clinic that is managing those medicines. And that's the same thing for chronic benzodiazepine therapy without a comorbid sedative hypnotic use disorder. Okay, this slide I really like to put on just to show that substance use disorders do not discriminate against anybody. It can be anybody and everyone who's walking down the street, regardless of their age, socioeconomic status, race, ethnicity, their medical comorbidities, you name it. So in general, I'd like to include this slide as well to highlight and emphasize the importance that providers have in knowing their own intrinsic and extrinsic biases in relation to patient care. So often patients with substance use disorders are viewed with a different clinical lens compared to other patients. And so I think it's really important for clinicians to be aware if we are viewing them differently because of their substance use disorder. So my recommendation is that all patients are screened for substance use and then subsequently substance use disorders if that is warranted. So let's say that a patient discloses substance use to you. Now what? The problem I've heard from other clinicians about why they're not screening for substance use or what makes them apprehensive about it is that they're not quite sure what to do when a patient says that they might have a substance use disorder or if they disclose any kind of substance use. So in general, I think the first and foremost thing that you can do for these folks is just approach them with openness in a non-judgmental manner. It takes a lot of courage for patients to be honest about their substance use. And so I tend to actually thank them for the strength that they have shown to share such vulnerable information with a healthcare provider. And so from there, I then also reassure that the information that they have shared with me is confidential, as long as it's not meeting the criteria that it is putting themselves at a risk to themselves or to others. But the confidentiality piece is really helpful to discuss with both adolescent patients and specifically patients who are pregnant, because the biggest fear for pregnant individuals is, are you going to take my baby? And CPS referrals, which I looked at the agenda for today's conference, and it looks like there's a couple of talks about this specifically. So I won't get into too much detail on that, but something that you can reassure pregnant individuals in Colorado is that you need to have two criteria met in order to refer to CPS, and you cannot report to CPS while patients are pregnant, unless it's about an already living child. But the two criteria that need to be met in order to report a patient to CPS is that the health of the baby is affected once they're born, and that the safety of the child is threatened by a parent's active substance use. So just having a history of substance use during pregnancy alone is not reason for a CPS referral. The next piece that I think is helpful to share with patients is that there are treatment options available. And so having a good sense of what those look like in your community is really important, because patients are scared to talk about their substance use if they feel hopeless or helpless that there's no treatment available. So feel free to refer them to addiction medicine. This is what we love to do, and it's our preferred patient population to see. And so if a patient discloses substance use, the next steps are pretty similar to any other chief complaint. It just really involves gathering a history. So a substance use history kind of contains five different components. I don't think that this is something that you guys need to have, down to a T, but I do include this slide just as a reference source for you in the future if you'd like. But similar to what Dr. Rosenberg said, I think one of my most important things that I like to highlight is this question right here, which is, do you use any substance to alter your mood or behavior? Because that's a really great catch-all question to figure out if somebody is using something to treat sleep or nausea or anxiety or stress in their life that might not be safe for them and for their baby in the long run. So my practice is I tend to ask patients about every single substance. I normalize it. I say, I ask everybody every substance. So please keep, the patients will laugh at me and they'll be like, no, I don't use any of that. Stop asking me. But I just still make a point because especially for certain substances, like in Colorado, a lot of patients don't think that cannabis counts as a substance that has potential addictive properties because it's legal. And so I make sure to ask about cannabis and psychedelics use. But yeah, other than that, it's pretty standard information like how long have you been using, the amount, the frequency, the route. I touch on any history of previous treatments that have been successful for patients, if there were medications that helped, or treatment interventions that really helped them stay in recovery. And then I touch on medical history, risk of infection, or comorbid medical conditions based off of their substance, and then a really detailed psychiatric history. So let's say that you've gotten all this information from patients, and now we're trying to figure out, do they actually have a substance use disorder or not? I will kind of break it to you, but it doesn't take a lot to meet criteria for a mild or moderate substance use disorder. And so these are kind of the big buckets that I think about when it comes to figuring out if the information that the patient has shared with us means that they have a substance use disorder. So the first three buckets are impaired control, social impairment, and risky use. So impaired control means that patients tend to start using substances in larger amounts and more frequently, and they have unsuccessful efforts at cutting back on the amount that they've been using. The social impairment can be anything from disruption in their home life with their spouse, their children, their family members, or at school if they're, in college or something, their grades are starting to fall, adolescent kiddos if they're missing school, truancy, things like that, and then work obligations as well. But then also a social impairment is if it's starting to present with some substitutions in what patients are doing. So for example, oftentimes patients with substance use disorders stop doing things that they used to enjoy, hobbies like hiking and running or whatever, and then they're spending all of their time trying to obtain the substance that they're using. So that's an example of social impairment. And then the risky use is pretty general as well, but I consider risky use of substances to be, for example, drinking and driving or using substances via the injection route because there are inherent risks with injecting medicines. So those are a couple of criteria as well that people can meet. And then the final bucket is the pharmacologic properties. I specifically leave this for last just to highlight that you do not need to have tolerance, withdrawal, or cravings for a substance in order to meet the criteria for a substance use disorder. This is often heard from patients who, I would say more frequently with alcohol use, they describe, oh, I don't drink every day. And if I don't drink for a few days, I don't experience withdrawal. So there's no way that I have an alcohol use disorder. However, that's when I bring out the list of the criteria and I show patients that, oh, we really don't need to have those physical symptoms. If you're meeting any of these other ones, you can meet criteria for a substance use disorder. And that's pretty telling for a lot of people. But tolerance, withdrawal, and craving also count, but they don't count in the setting of patients who are receiving and taking as prescribed prescription opioids or benzodiazepines. So think about the patients who have a history of chronic pain and they're needing more and more doses of oxycodone. Well, while they could be tipping into an opioid use disorder picture, the tolerance and withdrawal is expected with chronic use of opioids. And so those two criteria don't count if we're dealing with folks who have chronic prescriptions for medicines that have properties for tolerance and withdrawal. And so, like I mentioned earlier, it only takes 2 to 3 criteria to be met to meet for a mild substance use disorder. So think about it more frequently because there's probably a lot of people in the community and world who meet criteria for a mild substance use disorder just based off of the fact that you only need 2. Now, I wonder if I can see, oh, I can see the chat. Okay, I do have a question if you guys could put into the chat for me any ideas, but how do you think you do not diagnose a substance use disorder now that you've seen a list of criteria? What did you notice wasn't on that list? Yeah, labs, toxicology testing. That's right. Seeing a lot of labs. Great. So, yeah, that's exactly right. Labs is kind of the big one that I like to highlight. But also you can see that chart review is not on there. This is excluding, I will say, if somebody has a documented history of a substance use disorder where people have gone through the criteria, et cetera, et cetera. But looking at the chart and seeing that a patient has a prescription for oxycodone or Xanax or Valium, or that they have a positive urine toxicology test for amphetamines or methamphetamines, that is just a piece of information. It does not necessarily outline patients' whole picture of their life. And so the other thing, especially with urine toxicology testing, is that there's so many things that can cause false positives on the point of care tests. For example, SSRIs can cause false positives for MDMA or ecstasy. Bupropion can cause a false positive for amphetamines, and naltrexone, which is a treatment for opioid use disorder and alcohol use disorder, can cause false positives for oxycodone. So it's important to not see those results and automatically assume that a patient has a substance use disorder. Okay, so I apologize in advance for the following slides. They're pretty text heavy, but I mostly made them that way to provide a source of referral for you guys to look back on afterwards, because I'll send out my slides to those who are interested. But yeah, I'll kind of just briefly talk through them. Please ignore the text heaviness, but it's really just a source for a resource moving forward. But treatment of substance use disorders really falls along this continuum of care, which includes outpatient services, intensive outpatient, medical detox, residential treatment, sober living, and then therapeutic communities. I think the important thing here is that even though a patient may qualify or benefit from a really high level of care, like residential treatment or what people used to think of, as a 30-day treatment episode, even though they may benefit from that, does not mean that they're ready for that level of care. So I really encourage providers to meet patients where they're at. And if a patient says, oh, I guess I'll meet with an outpatient addiction medicine provider, but no way am I going to go to detox right now. Perfect. Send them our way. We are happy to meet with them and start building that rapport with them in the outpatient setting. That way, once they're hopefully ready one day for a higher level of care, we can help get them there quicker. So this slide just shows the flow of care and that people can kind of be plugged in at any single level. Okay, so the medications for opioid use disorder, and I've got a table coming up next, but the biggest thing here is that pharmacotherapy with a medication is the evidence-based treatment recommendation. So if a patient comes to you on any kind of opioid, oxycodone, fentanyl these days in the Denver community is really large, or if people can find heroin, things like that, the recommendation is not to just take them off of the opioid and go cold turkey. that has actually been shown to have much higher rates of relapse as well as a higher risk of overdose and death if those patients never sought treatment at all. Because once patients go off of these opioids, if they have no tolerance to the medicine, but they're struggling with cravings and they then return to use, since their tolerance levels will drop, they are at a much higher risk for overdose. So that's a big counseling piece that I have with patients. Okay, so here are the text-heavy slides. But the three big medications that we use for opioid use disorder are methadone, buprenorphine, and naltrexone. So methadone is a super old drug. It was actually discovered in 1937, but then received FDA approval in 1973 for opioid maintenance therapy. So it took a bit of time, about 40 some years for that to actually move forward. But methadone is a full opioid agonist. So it works similarly at the receptors compared to fentanyl, oxycodone, heroin, morphine, all of those, in which that it binds 100% at the receptor. It does have a really weak affinity for the receptor, meaning that it's not as sticky for the receptor. So you could give patients a different medicine that has a higher affinity for the opioid receptor, and methadone could get knocked off or kicked off. But the things with methadone to be mindful of is that right now, it cannot be prescribed from an outpatient setting. So myself at CeDAR, I cannot prescribe methadone for patients for opioid use disorder. Since methadone was originally created or discovered and then used to treat chronic pain, patients who have a history of chronic pain, usually in sometimes in like a cancer setting or for a hospice setting, they will get a prescription for methadone, but that is for pain, not for an opioid use disorder. If patients are receiving methadone for an opioid use disorder, they have to receive it from an OTP, which is called an opioid treatment program, or a methadone clinic. Other things to note for providers, if a patient tells you that they're on methadone from, let's say, Denver Health's clinic or the Arts Clinic, and you check the PDMP, it will not show up there because the methadone is dispensed from the OTP, from their own pharmacy that they have on site. So it won't show up in the PDMP because it's not a prescription. So those are the big takeaway pieces with methadone. Also, it's really notorious for different drug-drug interactions. So if a patient shares that they're on methadone, I would run a quick LexiComp search to see if any of the medicines you're prescribing them has an interaction with the methadone. The next big hitter that we use for opioid use disorder is buprenorphine. And so this is the one that I use more commonly because I can prescribe it from my clinic, but it comes in films and tablets, patches, and a subcutaneous injection. The name that you guys are probably more familiar with is like things like Suboxone or Subutex. But this medicine has a really high affinity for the opioid receptors, so it can displace and block other opioids. I really love buprenorphine for patients with opioid use disorders because it tends to have a safer respiratory profile than methadone unless it's combined with other CNS depressants. So that's the big counseling pieces with patients is that buprenorphine has been shown to have a ceiling effect with its dosing when it's used alone, meaning that it won't impact people's respiratory status unless it starts to get combined with things like alcohol or benzodiazepines. But the other thing that's kind of changed in the field of addiction medicine with buprenorphine is how we start this medicine. There is the potential that you can precipitate somebody's withdrawal if you give them buprenorphine too soon from their most recent opioid use. And so the traditional starts where we would just have people wait, 8 to 12 hours from their last opioid use and then give them a dose of 4 milligrams of buprenorphine have kind of changed a little bit in the age of fentanyl. And so you might hear people talking about microdose starts or low dose inductions, which is something that an addiction medicine specialist is more than happy to help provide for patients to help get them off of whatever opioid they're using. The third and probably less commonly used medicine now for opioid use disorder is naltrexone. It has been studied to show, and that was more so in the age of heroin and prescription opioids, to be beneficial for cravings for opioids, but not so much in the age of fentanyl. I haven't seen any recent data, but naltrexone works completely opposite for methadone and buprenorphine. So This is a full opioid antagonist, and it's got a really high affinity at the opioid receptors. So this can also displace and block other opioids. So instead of having any action at the mu receptor, it blocks it, meaning that if somebody is on naltrexone, either the pill or the once a month injection form called Vivitrol, and they use opioids on top of it, they will not feel the effect of the opioid. So it has a really good benefit from that stance, but it's hard to get people on this medicine for opioids because they need to be opioid free for about 5 to 7 days before they start. So that's the biggest challenge with naltrexone. But sometimes it is still an option if patients want a medicine where they don't have physical dependence to it, which is still present with methadone and buprenorphine since they are full or partial opioid agonists. So that's a big summary slide for medications for opioid use disorder. Now we have the summary slide for medications for alcohol use disorder. And you'll notice that naltrexone is on here as well. Naltrexone is my go-to medicine for patients with an alcohol use disorder. It's been shown to be very effective and it's safe in many different patient populations. So I won't go into that one anymore since I just spoke about it. But the other medicines that we use, kind of the three big ones are acamprosate, disulfiram, and naltrexone. Acamprosate, the problem with this one is that it's got a really heavy pill burden, meaning it is 3 pills 3 times a day, which can be really challenging for some patients. And so for that reason, it's not usually my go-to medicine. And then we have something called disulfiram, or Antabuse is the common name. But this medicine, the way I describe it to patients in a way that it seems to be they're able to understand it a bit better, is that it kind of gives you an allergy to alcohol since it's blocking the metabolism of the aldehyde dehydrogenase. So you get a buildup of acetaldehyde, and then from that you get this, quote, allergy, which looks like flushing, palpitations, tachycardia, nausea, vomiting, shortness of breath, sweaty, and dizzy. You'll often hear patients say when you offer medicines, they're like, well, I don't want that one that's going to make me sick if I drink. And they're talking about disulfiram. So the biggest piece with this medicine is that you need to counsel on the avoidance of alcohol-containing products and foods. Everybody is different when it comes to the sensitivity of the presence of alcohol in foods or like beauty products. So if patients are worried about it, I just encourage them to do a spot test on their skin if they're using a beauty product, or taking a small sample of something so they're not getting a huge reaction if they are more sensitive. And then we have this other group of medicines that are used not as commonly, but they're still an option. And the data on these ones is kind of mixed, but topiramate is an option. However, it's got a pretty difficult side effect profile. So I don't use that one as often. Gabapentin I do use pretty frequently. You can titrate up to 900 milligrams 3 times a day, and that's the dose that's been shown to be effective for alcohol cravings and for PAWS, which is post-acute withdrawal symptoms, which basically means the persistent anxiety, insomnia, and irritability that people experience when they come off of alcohol. And then there's baclofen, mixed results. And if folks are asking about psychedelics, I just make sure to kind of provide or debunk some of the thoughts that they share about, microdosing will help or macrodosing this frequently will help. The research shows it. So I try and debunk that by sharing the one study that I'm familiar with right now is that psychedelics have shown to have some promise in the treatment of alcohol use disorder, but that was when the macrodose was administered only on 2 occasions in combination with an hour-long psychotherapy session. So that is kind of the big thing that I like to talk with patients when they ask questions about how do psychedelics help with alcohol use disorder. And then this is just a summary slide. I didn't do a whole slide on stimulant use disorder because there really isn't a ton that we can do for it. The medication combination that we do have is the IM naltrexone version plus high-dose bupropion. And so we'll use that for folks, and that's got mixed data, but it did seem to be pretty positive. And then the best treatment option for for stimulant use disorder is a behavioral intervention called contingency management. It's almost a gamification of therapy, which I think is really great, but patients essentially get rewarded for desired behaviors, whether that be coming into an IOP appointment, coming into their provider appointment, having expected urine toxicology testing. You can kind of build a contingency management program however you want, but it has been shown to be beneficial for stimulant use disorder. Okay, now we'll get into some of the treatment considerations that providers should have when folks are pregnant, and then a little bit later, some for pediatric providers for adolescent patients. But the biggest things for pregnancy or patients who are pregnant is that we should be screening all pregnant individuals for substance use. But make sure that we're doing that with a validated tool and not a toxicology test, because as I spoke about earlier, using a urine toxicology test is not a way to determine if somebody has a substance use disorder. The other big thing to share with pregnant individuals is that there were legislative changes made in 2020, in Colorado specifically, that stated that substance exposure during pregnancy is no longer considered child abuse or neglect. I think that's a really helpful thing to share with pregnant individuals because it can help ease some of their fears about what happens to their baby once it's born. And so that really can help provide patients the comfort to share history of substance use, because engagement in care overall can help patients have better maternal and fetal outcomes, even if the person does not reach total abstinence during pregnancy. So sharing that, I think, is really, really helpful for patients. So if we think about opioids and the considerations for pregnancy and postpartum, the biggest things that I share with patients is that the risk with opioid use in pregnancy is if you have untreated withdrawal symptoms, that can put a patient and their unborn child at risk for preterm labor and spontaneous abortion. So that's really what we're trying to avoid in pregnancy. So if a patient comes to you and they're pregnant and they say that they're using opioids, the recommendation is not to have them cut it off cold turkey, because we'd want to do it in a controlled way to minimize the symptoms of withdrawal to help protect the maternal fetal health. The other things to share with those patients is that there are really good treatment options available that are safe in pregnancy. So both methadone and buprenorphine have been determined as safe in pregnancy and for breastfeeding. The other thing that I've got a different slide on later is that the development of NOWS, or it used to be known as neonatal abstinence syndrome, but now it's been kind of renamed as neonatal opioid withdrawal syndrome, the development of that does not depend on the dose that a mother is taking of methadone and buprenorphine. So the pregnant individual could be on 95 milligrams of methadone or 200 milligrams of methadone, and we wouldn't know if that child would develop NOWS or not because it's not dose dependent. The other big thing to share with these folks is that medications for opioid use disorder are recommended, and there's no expected long-term adverse effects on growth, development, or behavior in children of people who utilized medications for opioid use disorder in pregnancy. What I do share with folks is that there are unknown effects of using illicit opioids like fentanyl that are often pressed with several other kinds of opioids or other substances that we just don't know about. And those effects on the fetus or the fetal development is unknown. So that's where, if we're thinking about risks and benefits, there are some known risks to methadone and buprenorphine, that being the development of neonatal opioid withdrawal syndrome. But the benefit is that we know that there's no long-term adverse effects with those medicines. Okay. A point on alcohol, which I think somebody mentioned in the chat at the end of Dr. Rosenberg's lecture, but something that's helpful to debunk for pregnant patients is that no amount of alcohol is deemed good for health or safe during pregnancy. So this can really open up a critical conversation with pregnant individuals when you share this information and kind of seeing how they react. And you can just start the conversation, by saying, if I tell you that no amount of alcohol is considered safe in pregnancy, how does that make you feel? And, does it feel scary to think about, or does it feel difficult to attain? That might help identify different patients who would benefit from treatment resources for their alcohol use if they feel like it's a difficult task to obtain when you share that they shouldn't be drinking anything during pregnancy. So for the treatment options, naltrexone has been shown in some animal studies that it may have effects on the growth of the fetus. However, the benefits of alcohol cessation during pregnancy outweigh those risks. Because the known risks of continued alcohol use during pregnancy is fetal alcohol spectrum disorders. And so, what I share with patients is that while, yes, there might be the chance that your baby is a little bit smaller, we have ways to monitor for that. Versus the fetal alcohol spectrum disorder would be a lifelong condition that the baby might have to deal with. So that's the counseling piece that I share with patients in regards to alcohol. And then for tobacco, anything that can constrict the blood vessels flowing to the placenta and to the fetus can affect the growth and development of the baby. So the risks of continued tobacco use during pregnancy is the risk of decreased birth weight, preterm labor, placental abruption, and SIDS. And then the thing to share with these individuals is that replacement therapy, so nicotine replacement, varenicline, or bupropion are safe in pregnancy if they're interested in cessation. But the thing to know, especially after Dr. Rosenberg shared if folks are vaping, these people might need much higher levels of nicotine replacement, like a couple of patches, multiple lozenges a day on top, in order to help manage their cravings. And then finally, for cannabis, there is the misconception for a lot of pregnant individuals that cannabis is safe in pregnancy. However, it has been shown to cross the the placenta and is detectable in breast milk. The risks that Dr. Rosenberg shared as well, so that was a great precursor for this presentation, is that there are increased risks of preterm birth, low birth weight, and higher chances of NICU stays, as well as neurodevelopmental deficits. So ACOG and AAAP both recommend to abstain from cannabis use while breastfeeding. One thing that you can counsel patients who are using cannabis, if they want to try and have some neuroprotection for their fetus, is that there have been some studies that show that higher choline concentrations in pregnant individuals who used cannabis seem to provide some sort of protection against impacts on a child's attention problems in their early developmental years. So you could consider offering increased choline supplementation for pregnant individuals if they're still using cannabis. Okay, and this is just the medications and considerations for patients if they're pregnant. But the things to know for methadone is that oftentimes patients are requiring 3 times a day or even 4 times a day dosing as their pregnancy progresses. And they're going to need much higher doses because of the change and increase in liver metabolism. But methadone, buprenorphine, and naltrexone are deemed safe in pregnancy. For naltrexone, with that risk of intrauterine growth restriction, we do recommend that you complete a growth ultrasound at 32 weeks or sooner if there's concern for fetal growth. And since naltrexone is an opioid receptor blocker, we do recommend that the last long-acting injection is completed at 35 weeks, or you stop the oral dose 3 to 5 days before a scheduled C-section or at the first signs of labor, in case if a mother wants to have fentanyl within the epidural, which is a really common medication that people will use during pregnancy for pain relief. Okay, this is just a resource slide, so I'm not going to go through all of that. And it's exciting to see that some of these locations who take patients who are pregnant for substance use treatment are actually presenting today. I think I saw New Directions is presenting today, and then some folks from Hard Beauty will be giving a talk later today, so that's really exciting. But yeah, just for your reference, if you are ever curious about what places will take women who are pregnant or recently postpartum. And finally, just some pediatrician or pediatric provider considerations. As Dr. Rosenberg mentioned, the neonatal evaluation and documentation of prenatal substance exposure is really important. And so what I like to highlight here is that when you ask patients about prenatal substance exposure, I think it's helpful to normalize it, which I'm sure most people are. But one way that's helpful to kind of frame it for folks is that not everybody knows that they're pregnant originally or they're planning for pregnancy. And so sometimes people are using various substances recreationally before they find out that they were pregnant. If that was you, like, is there anything that you'd like to share or any substances that you were using before you found out that you were pregnant? So that's kind of a curious and non-judgmental way to approach the question. But then a quick note on the recommendation against meconium or umbilical cord testing. So ASAM, or the American Society of Addiction Medicine, does not recommend that we use these testing things because it really doesn't change our clinical management. These tests can take anywhere from 5 to 7 days to come back, so there really isn't any clinical utility in guiding the management of hospitalized infants. Also, these results may reflect iatrogenic exposures to medications that pregnant individuals received during labor. Um, I think it's important to know that infant urine can show substance use within the last 1 to 2 weeks of pregnancy, and then infant meconium in cord blood can show exposure anywhere from 20 to 24 weeks of gestation. So those results may not actually clinically reflect how the pregnant individual was doing from a substance use disorder treatment standpoint. Um, okay. And then for adolescents with substance use disorders, it is state dependent, but in Colorado, minors can consent for their own treatment of a substance use disorder. And all of the medications that I mentioned before can be used for patients who are less than 18 years old. I guess now that I say that, except methadone, you have to get special privileges or special state approval if you're treating a patient with methadone who's less than 18 years old. But in order to find these individuals, it's important to use validated screening tools. And those are things like the CRAFT and the S2BI, which I've just included here for your reference. And then this is a list of locations that I know take adolescents for treatment of substance use disorders. The two biggest ones that I'm familiar with are the Denver Health Step Clinic and Synergy, but these other ones also will take adolescents. And then finally, just a piece on harm reduction. Not everybody is ready to meet, is not ready for total abstinence or total cessation of their substance use. So I think it's important to offer resources for how to help them use substances safely, whether that be needle exchange programs, making sure that you offer everybody naloxone or Narcan to help prevent death, and then provide screenings for different infectious diseases. Yeah, I'm trying to get this done within my time frame. This is just a resource page. And then a thank you to everybody. Any questions? I'll stop sharing my screen. Sorry, I know that was kind of a lot.
I had a quick question with the child welfare piece of reporting. Is it correct
Yeah.
the individual hospitals, though, may still report? So even though there's this law present, the hospital will still report?
Yeah, that's correct. And so that's kind of the advocacy piece that I think is important to know, is to know like what your hospital system is doing. And if they are just one, automatically grabbing urine toxicology or cord blood testing on every patient when it's not indicated or without their consent, I would try and be an advocate for patients to not do that or to try and get those hospital policies changed. Because yeah, that's true. Even where I trained in Grand Junction, I thought that was just standard that you reported everybody to CPS. I'm like, oh wait, that's actually not true. So yeah, it is hospital dependent, which is unfortunate.
Okay, great. Thanks so much.
Yeah. And then I see a question in the chat. It says, is cord blood collection a mandatory practice or do patients have to consent? My understanding is that patients have to consent to having cord blood obtained. But again, that could be more hospital policy. So I would check with whichever organization you're working with. But my practice is anytime I'm obtaining a test or a lab on somebody, I'm going to make sure that I have their consent. Oh, and then I think I saw is it possible to share the resources page? Yes. I'm not sure if they're going to send out our slides, but I will send it to the organizers of the conference and then hope that they can distribute it to people who are interested. Okay. Any other questions? Yeah, fetal alcohol spectrum disorders are not uncommon. So yeah, it's very important to mention that to patients. Cool. Well, thank you so much, everybody. It was great chatting with you and enjoy the rest of the conference.